Audio check. 1, 2. Audio check.
Good evening, everybody, and welcome to this, another one of our webinars that we've been holding roughly about 8 or 9 times a year. This particular webinar will be on the topic of secondary infertility, and we'll start in a few moments. I just want to introduce this by a few housekeeping messages that I think you need to get. Firstly, this webinar is going to be 30 to 40 minutes in length, and then it will be followed by a question and answer session, and you can begin by posting your questions now in the chat box on the right side of your screen if you like. Second is, this webinar is going to be recorded and archived on this page, so you can always come back to it if you miss anything and you'd like to view it again. So feel free to come back and watch the webinar at a later date, or tell your friends about it if you like. I also want to invite you to my blog, ivfauthority.com. As you probably are aware, I write articles on this every week or two, and I try to keep each article different and to be substantive and informative for you. Please go to the blog and read these articles as they come up. And there's also a comment box where you can actually type any questions or raise any issues, and those of you who go there know that I'm there very frequently, and I like to keep answering your questions as they come up. Please go there and post any questions you like. Also visit our discussion board at forums.haveababy.com. Any of you would like to schedule a Skype consultation with me, please dial 800-780-7437. Tina will pick up, and simply tell her, set a time for a consultation. I'm very busy at the moment. I'm booked all the way into next year, well into next year. So those of you interested in talking to me about your particular problems, just call Tina tomorrow or any other day during the week at 800-780-7437 and ask her to schedule you for a consultation. You can also visit our website, haveababy.com. The SRM Las Vegas discussion board is on that site, and all you do is find the SRM Las Vegas discussion board, and there's a question and answer session there as well. Just type any questions that you like on that site, and I go there regularly and will answer those as well. Just a little bit of information. I've had a lot of people write to me and email me about repeating a previous webinar that I've already done on immunotherapy for infertility and recurrent pregnancy loss, including people who can't get pregnant for unexplained reasons, recurrent miscarriages, unexplained IVF failures, all these things. And there will be another webinar that I'll hold on January the 29th at this time. I urge you to make a note of that, and if you want to attend, you'll be welcome. Also, watch our Facebook page or email tomanderson@integramed.com if you want to register. Again, tom.anderson@integramed.com if you want to register in advance for that seminar. So then let's get started on secondary infertility. By definition, this is a condition where infertility occurs after having conceived once in the past. And if after having conceived once, more than a year elapses of trying, and you're unable to conceive, we call that secondary infertility. What is little understood is that 11% of couples who've already had a child, go on to experience secondary infertility. I mean, that's a big number. It's approximately 4 million couples, or about half of all the infertility cases in the United States are secondary infertility. Most people who don't get pregnant after having had a baby or been pregnant before can't understand why that happens. And what you need to know is that there are very legitimate causes. Most of them are the same causes that cause primary infertility. But there are one or two that stand out specifically that I'm going to focus on, and that's number 6 and 7. Endometriosis and immunologic implantation dysfunction are very common causes of unexplained secondary infertility, and I'm going to spend quite some time on these last two when I get there. But as I said, the common causes of secondary infertility are the same as those factors that cause primary infertility. That means unable to conceive from the very get-go. So let's start. Firstly, there's maternal age. As women get older, there is a natural decline in fertility. Here we're looking at the percentage of eggs that will be chromosomally normal, and that basically mimics the incidence of infertility in any age category. In young women, roughly 1 in 2 eggs are normal, but as a woman gets older, a greater number of her eggs will be abnormal and a smaller number will be chromosomally normal. If the egg is chromosomally abnormal numerically, that means it's got more or less than the natural normal number of chromosomes it should have at the point of ovulation or extraction. Such an egg is incompetent and will not be able to usually propagate a viable pregnancy. Either the embryo, the egg, when it fertilizes and forms an embryo, will stop dividing, or the embryo will not attach. And if it does attach, it'll attach for a very brief period of time, which is exactly why we see that the incidence of miscarriage also increases with age, as the incidence of aneuploidy or chromosomal irregularities in the egg increases, so the incidence of miscarriage also increases. I wish to point out, however, that we're talking about spontaneous miscarriages here. That means if you look at a population and all the miscarriages that occur, roughly 80% of them will be due to a problem with the egg, with the embryo originating in the egg being chromosomally abnormal. In other words, the commonest cause of miscarriage remains chromosomal abnormalities of the embryo that starts with the egg, in most cases. But that doesn't apply when you have repeated or recurrent miscarriages. In such cases, it's not commonly due to chromosomal irregularities because they don't keep recurring over and over again. So when a woman miscarries 3 times or more in a row, and we call that recurrent miscarriage, such miscarriages are more commonly not due to the embryo being abnormal, but more likely to be due to the uterine lining being non-receptive to the embryo because of a variety of reasons, including anatomical problems in the uterus, and we'll be talking about this later, including also the uterine lining being too thin or scarred, or polyps being present in the uterus, and a large chunk of these are also due to immune factors, which we'll talk about later on. The important point is that when women have a child when they're younger and then they decide to delay having another child for some time, they often find it to be more difficult to get pregnant because the greater the likelihood that the egg that they ovulate every month will end up being abnormal and not propagate a baby. So age is an important factor. The second one is male factor infertility, and most of you are aware what the normal parameters of the sperm are in terms of normalcy. We need to have a concentration of more than 20 million sperm in a milliliter of ejaculate. More than half of them need to be normal in their movement, and they need to move in a linear fashion. They need to be able to move linearly forward. And there is 4%, in 4% of cases, and then there is the morphology, the shape of the sperm, where you need to have at least 4% of them normal. This is using so-called Kruger classification or strict criteria on sperm morphology. By this classification, at least 4% of sperm need to be normal. But there are many causes of secondary male factor infertility. Here's a list of them. I don't intend to go into them in detail, but obviously trauma to the testicle can cause leakage of sperm. This can cause the body to produce antibodies against your own sperm, and this in turn then can turn out to block the ability of sperm to penetrate an egg. Or the trauma can so disrupt the collecting system of the ducts in the testicles or surrounding the testicles that they get blocked, and as a consequence of this, sperm is unable to reach ejaculation. Now, there are other causes that can also block the ducts that collect and carry the sperm through the penis during ejaculation, and these can be inflammatory. Things like gonorrhea and chlamydia can cause this, or you can get very severe infections which we don't see so much in the United States, such as syphilis and tuberculosis, that can destroy testicular tissue completely. In most cases in this country where there's an inflammatory cause of sperm dysfunction, it's usually due to the fact that the ducts are blocked by gonorrhea or chlamydia. So the sperm can reach the ejaculation phase from the testicle. There is a condition called varicocele, which often develops as men get older. Here, these are veins that collect around the testicles in the scrotum, and they heat the environment. Remember, the testicles are outside the body in the scrotum in a bag because the temperature inside the body is too hot, too warm for them to survive properly. So that if you have a lot of veins collecting, like varicose veins, we call these varicoceles, they can heat the environment in the scrotum, and sperm will not develop properly in the testicles if the environment is too warm for them. Treatment is to cause to tie off the spermatic veins or obliterate them by sclerosing them with through radiological intervention, where you pass a catheter down the spermatic vein and then cause the vessel to be blocked, thrombosed, and then it'll seal off and the varicose veins or the varicocele will collapse. Most varicoceles are innocuous. A man goes to see his urologist. The urologist examines him and says, it feels like you could have a varicocele, and they, to palpation, it feels like literally a bag of worms. And then he does an ultrasound and can make the diagnosis. But a varicocele does not cause sperm dysfunction very often. In fact, it's more the exception than the rule that it does cause a problem with sperm production. It has to be quite severe for it to do that. The next is surgical, of course. Men have vasectomies, and they think that because after the vasectomy they can have it reversed and reconnect the ducts, even if you do it in a proper fashion, that those ducts will then be able to function normally. That is, they may be patent and they may be able to allow the sperm to pass. But if the vasectomy reversal is done more than 10 years after the vasectomy was done, there's usually the man will usually produce antibodies against his own sperm, rendering that sperm unable to propagate a baby. And in such cases, the man is then permanently infertile. The only way to treat that is with IVF and ICSI, where you inject each sperm into an egg, or one sperm into each egg, to fertilize it. There's no other really reliable way of treating it. We used to use methods to try and separate the antibodies in the ejaculate by letting the sperm swim through beads, through acrylic beads, in the hope that by shaving past these beads, the antibodies will be shaved off, but it doesn't work. The only way is to get to the sperm and then inject one sperm into each egg, and that solves the problem. In men that have had a previous vasectomy and the vasectomy reversal, and this fails to satisfactorily reconnect the ducts, we can go into the testicles with a needle through a procedure known as testicular sperm extraction and remove sperm directly from the testicle and use that for injecting it into an egg. And the pregnancy rate is no different than with conventional IVF when you do that. There can be toxic factors. A man can be exposed to environmental factors, heavy metals, and so forth. It can also be as a consequence of exposure to radiation or to chemotherapy that can cause the testicles not to produce viable sperm. And this has to be taken into consideration. In many cases, you don't know what the environmental factor is that you're exposed to. The man has no idea why his sperm is no longer functioning properly. And we often don't even find the cause. The treatment in such cases is difficult because if the sperm has been toxified, very often the DNA in the sperm has also been damaged. In another percentage of cases, as men get older and it's not as prominent as it is in women, the testicles can fail. And you can start getting almost like a male menopause developing. And when that happens, sperm function declines. And again, the man can unexpectedly be saddled with secondary and unexpected infertility. And then, of course, we know that ejaculatory and erectile disorders occur more frequently as men get older, and or for psychological reasons. And where there is this kind of problem, it can cause a secondary infertility issue. Treatment is often use of drugs like Viagra to try to increase erectile function, or in cases where that doesn't work, then it is possible again to extract the sperm directly out of the testicle through tessie as described above, and inject the eggs with one sperm into each egg. Now then we come to the next common cause of infertility, and therefore also secondary infertility, and that is where the tubes get damaged. This is a picture, a hysterosalpingogram, or a dye X-ray picture, where dye is injected through the vagina and the cervix into the uterus. This is a radio-opaque dye, so it passes into the tube and X-rays won't pass through it, and that's the white area that you see. So here we see a normal HSG with a normal shaped uterus, the dye passing through the tubes, sorry about that, and then going to the ends of the tubes and spilling out through the finger-like projections at the end of the tubes. This is a perfectly normal hysterosalpingogram. This hysterosalpingogram is obviously abnormal. Here's the uterus. The dye enters the tube, but these tubes are blocked at the end. They're clubbed. And why are they clubbed? They're clubbed because they've been damaged usually by infection. This doesn't happen with endometriosis because endometriosis doesn't damage the tube's wall. It is usually on the outside of the tube. But with tubal inflammation, with gonorrhea and chlamydia especially, the inner wall of the tube, the inner sophisticated lining is damaged, and the wall of the tube is permeated by the infection and inflammation, and it's damaged such that it stretches when the ends are blocked. Why are the ends blocked? Because it's nature's way of walling off an infection to prevent it spilling out into the abdominal cavity. So the ends of the tubes, which have finger-like projections, fold in to wall off the infection, and the pus develops inside the tube and distends the tube, gets into the wall, and then weakens the wall so that it's more likely to distend into these bags of fluid, which at the end of the day, when the pus absorbs, is left with a looking like straw-colored fluid or darkened or altered discoloration of the fluid in the tube. This is a real problem. With this problem, you've got to remove the tube, or at least ligate it, block it, clip it, right here where the tube leaves the uterus, so that when the IVF is done and embryos are put in the uterus, the fluid doesn't flow backwards back into the uterus and toxify the embryo. So it's important to know if there's this distension of the tube with fluid, which we call hydrosalpinx. And again, this is commonly due to sexually transmitted infection with chlamydia and gonorrhea. It can occur any time in a person's life, so that you can have had a child and then subsequently become infected through sexually transmitted infection, and then it can go to the tubes and leave you infertile and wondering why it is that you had one baby but you couldn't have another. Treatment of this is, again, blockage or removal of those tubes, and I prefer the latter, laparoscopic removal of the tube, because why leave a pathological structure in place to possibly cause more problems in later life? And then to do in vitro fertilization, to bypass the damaged plumbing. This is another blockage of the tube, and here I want to pause for a second. This blockage has occurred right here where the tube leaves the uterus. The commonest cause of this type of blockage is previous infection after a pregnancy, be it after a septic abortion, incomplete abortion, or after the birth of a child, where products of conception of the baby are retained in the uterus. They then die and become necrotic, and act as a beautiful culture medium for bacteria which ascend through the vagina into the uterus and grow there. And then they travel to the uterus, to the point where the tube leaves the uterus, the narrowest point here, and they block the tube at this point. When this type of blockage occurs because of infection, it usually cannot be undone by passing a little wire through it and cannulating the tube from the inside through hysteroscopy. It usually, if you're going to do surgery on it, requires opening the abdomen or going through the laparoscope, removing the end of the tube, and then reimplanting the tube into the uterus. This is an outdated procedure which is of historic interest only and should not, in my opinion, ever be done any longer. The treatment is to do IVF, remove the eggs, and put the embryos in the uterus, and the results are very, very good, provided that the uterine lining hasn't been damaged through the infection. If the uterine lining has been damaged by the infection, it will usually result in, let me just see if I can find it. It'll usually, I'll show it to you later, usually result in the lining of the tube being very thin and incapable of responding to estrogen. This type of thin lining, and I'll point to it later, is usually resistant to estrogen, and it's even resistant to Viagra therapy, which improves the blood flow to the lining and carries more estrogen to the lining to make the lining develop. It won't respond usually very well in about 60% of cases. When it doesn't respond, you have a real problem. If the lining's under 8 millimeters on the day of ovulation or the day of the HCG shot, then usually that uterus is probably not going to be able to carry a baby. Or it'll cause the pregnancy not to develop properly, and there'll be growth retardation of the baby, or the placenta won't attach properly, and you'll have problems such as separation of the placenta through a very serious condition called abruptio placentae with bleeding in later pregnancy if the pregnancy grows, or the baby will develop slowly and have growth retardation. We call that intrauterine growth retardation. So it's important to be able to be sure that the lining of the uterus is at least 8 millimeters and preferably over 9 millimeters when you administer the HCG trigger shot, and then later go and remove the eggs for an egg retrieval. The other thing that often happens with infection following on a pregnancy, and I emphasize this rarely occurs without a preceding pregnancy, is that scar tissue develops, and this scar tissue causes fusion of the lining with dense adhesions in the uterus known as Asherman syndrome, and I'll show you that later on as well. So what do we need to know about tubal factors? About 25% of infertile couples will have a tubal factor. The common cause is chlamydia or gonococcus. Tubal surgery is again of historic interest. Internal tubal surgery is not repairable because you can't fix the sophisticated lining of the tube or restore the uterine wall if it's been damaged through infection. And most cases where you will try to do that will reblock or reocclude within 6 months. And if you do get pregnant after a tubal surgery, you're set up for the risk of a tubal pregnancy, which can be life-endangering if it ruptures. It's called an ectopic pregnancy. So the best thing is to remove any hydrosalpinx if there's a bag of fluid in the tubes before you do IVF, or at least ligate the tube as it leaves the uterus to prevent the toxic fluid in the tube draining back into the uterus and damaging the embryo. I'm not going to go into ovulation dysfunction, but it's pretty well obvious that ovulatory problems can occur anywhere in a woman's life. She can have normal ovulation, have a baby, and then fail to ovulate, or she could have irregular dysfunctional ovulation, get pregnant once, but not get pregnant easily later on because she's getting older, egg quality is declining at the same time. In some cases, in older women, there's a risk, and in women who've got diminished ovarian reserve, that means their eggs are running out, and we pick it up by testing their FSH, LH, estradiol, and anti-Mullerian hormone, AMH, at the basal level for convenience, usually in the second, third, or fourth day of the period. And if a woman's got diminished ovarian reserve or she's older, she's at greater risk of premature luteinization and a condition known as luteinized unruptured follicle syndrome, where the egg is not released from the follicle, it stays inside the follicle. Please bear in mind, folks, there's no such thing as an empty follicle, because all follicles have eggs in them. The question is, will the egg come free? And sometimes it doesn't if it's grossly abnormal. If it's grossly abnormal because of age or because of the type of protocol of ovarian stimulation used, treatment of this problem requires a lot of attention be placed on selecting the ideal individualized protocol for ovarian stimulation, which there's no time to go into now and which we've dealt with in a previous webinar. Then we come to the number 5, which is uterine pathology. This is the uterus again, a picture of the uterus, and you'll notice fibroids in the uterus. These are growths in the uterine wall that can be in the muscle or be protruding into the uterine cavity, like here as a polyp. We call that a pedunculated polyp because it's like a mushroom on a stem. All you have to do is remove it through a hysteroscope by transecting it as it leaves the wall. Then there is the uterus that is submucous, the polyp, the fibroid that is submucous. It protrudes into the uterus, but most of it or some of it is growing in the uterine wall. There's a tendency of many doctors to try to shave away this part of the fibroid so it then is flush with the uterine wall. That's not a good thing to do, because if you do that, it will still cause a local irritation, which makes it harder for an embryo to attach. Then there are fibroids on the outside of the uterus. We call them subserous, being that the outer lining of the uterus is called the serous layer. And also then there is another form of subserous fibroid, which is like the one inside here, is on a little stem or a pedicle. It's called a pedunculated fibroid. These don't usually cause problems unless they twist or grow too large and run out of their blood supply, and then they cause pain. So the removal of these fibroids is important. The traditional way to remove fibroids is to go in through a laparoscope and remove them robotically. You want to try to remove them without opening up the cavity in the uterus here, because if you do, you can cause scarring to occur, and that can be just as bad as the fibroids. There is also a method that is now coming into vogue, where we use ultrasound to focus on these fibroids and destroy them with high-frequency ultrasound waves. This is very, very new. It is an Israeli innovation, and it is entering into the United States. It's now been approved by the FDA for treatment of fibroids. It will mitigate the need to do surgery in many cases. When the fibroid's protruding into the cavity, you still have to go in and remove it with the hysteroscope by removing it by transecting the stem. But if it's in the wall of the uterus, or if it's submucous, as it is here, sessile, and not on a stem, or if it's in the wall of the uterus, you can go in and have it and destroy it with high-frequency ultrasound waves. This is the treatment of the future, I believe. There is a treatment that became vogue within the last decade or so, and that was to try to embolize these fibroids, to inject little microspheres into the uterus that block the blood vessels that feed the fibroids with blood, and then they shrink away. That's all good and well for women that don't want babies, but very often if you do that, you also shrink the blood vessels that feed the lining of the uterus, and the woman can't produce a good lining to carry a baby properly. So for that reason, I don't recommend embolization for infertile women. This is a picture of an Asherman's type syndrome. That's where there's scarring inside the uterus. And please notice here, this particular picture shows a dense scarring where the dye did not go in the uterine cavity and irregularities on the surface. This is Asherman's syndrome. As I told you, it occurs following an endometriosis, which is infection of the uterine lining following a preceding pregnancy, where products of conception were left behind, which is why we see it in women after childbirth, if the whole placenta didn't come out, or after an incomplete abortion, or after a miscarriage that was neglected. It's a good idea, in my opinion, in a woman who miscarries to go in and clean out the uterus so you can avoid there being any leftover tissue that can cause this kind of problem. And this is a sonohysterogram where we inject water into the uterus. And here you can see a little polyp inside the uterus, which will interfere with the ability of the uterine lining to be receptive. And you can see it's a harmless T-break, small, minor procedure that doesn't cause a lot of problems. And all you do is you go in through a hysteroscope or DNC, and you take out the polyp, doing a polypectomy. It's a minor procedure, but is essential to do. I do sonohystograms, or hysterosonogram as it's also known, on all my patients doing IVF if they've not had one done in the preceding year. This is a hysteroscopy looking inside the uterus, and here you can see a polyp protruding. This is where the polyp was removed, and you go back in to look a few months later to make sure it's gone, and you can find that the uterus is clear. I spoke to you earlier on about the uterine lining. We were the first people to point to the fact that you need a uterine lining that measures ideally over 9 millimeters on the day of HCG for a good chance of a successful implantation. Otherwise, it's like having not enough soil in the planter box for the roots of the embryo to grow into. And this is a good lining. Notice it measures 11 millimeters and it's trilaminar. It has a layer in the middle where the two walls of the cavity are in apposition, and this shows you the inner basal layer of the uterus, of the lining, from which the new lining develops every month. So this is a trilaminar, triple line appearance with the walls in apposition, and the thickness is perfect. The uterus also looks perfectly normal. Here's the cervix leading into the uterus. This is a good uterine lining. But there are cases where you get a poor uterine lining. Here is a classic example. This is an ultrasound done just before the HCG trigger. Notice this only measures 5.8 millimeters in thickness. And this lining is not compatible with harboring a healthy pregnancy. There's not enough room for the root system of the embryo to grow. One of the common causes of this is where there's been previous endometriosis caused by gonorrhea or chlamydia that has damaged the basal layer. You'll remember me telling you, the layer from which the lining sprouts every month on the outside here. The basal layer of the endometrium is damaged so it can't produce a proper lining. In many of these cases, there's also Asherman syndrome, as I pointed out, where there's scar tissue inside the uterus as a result. Here is another picture of a hysterosalpingogram showing dense scarring tissue, these areas inside the uterus, as a consequence of infection, endometriosis that occurred usually after a previous miscarriage, abortion, childbirth, or hydatidiform molar pregnancy. Okay, now we get to the two most important. Now, why did I leave these two for last? I left it for last because these are often the two most overlooked causes of unexplained secondary infertility. Remember, when the lining of the uterus or the endometrium grows outside the uterus in the pelvis, it releases toxins into the pelvic secretions. These toxins get into the thin layer of fluid that surrounds all the pelvic organs on the surface of the membrane that covers or envelops all pelvic organs, known as the peritoneum. Of course, this fluid, the purpose of it is to allow the organs to lubricate so they don't stick together and cause scarring. If the toxins from even the most minute amount of endometriosis get into this fluid, then the egg leaving the ovary to get to the tube where the sperm is waiting has to pass through this environment of toxins. That's much like trying to swim across a river full of alligators and hoping that when you get out to the next bank, on the other bank, you'll be in good shape to travel into the interior. Obviously, that doesn't always happen. So when there is endometriosis, the ability of an egg to pass from the ovary to the tube so that by the time it gets to the sperm still be able to be fertilized easily is reduced dramatically. The egg of the human looks just like the egg of a chicken, only it's the size of a grain of sand. and the envelopment or the shell is much softer. Now the sperm has to penetrate through this envelopment known as the zona pellucida. And as the egg passes through an endometriosis environment, it's passing through an environment that hardens that envelopment and makes it less likely for the egg to be able to penetrate. And that is why pregnancy rates are so much less, even in women who ovulate regularly with fertile partners, but have even minor amounts of endometriosis. Because as the egg passes through the pelvic cavity to reach, after ovulation, to reach the tube where the sperm is waiting, the zona pellucida becomes impervious to sperm. Let me give you an example. If a woman of 32, 33 would have a 20% chance of getting pregnant in any given month if she had a fertile husband and open tubes and had no endometriosis, and about a 15% chance of giving birth to a child per month, and an 80% chance of having a baby per year of trying, that's if she has regular intercourse around the time of ovulation, with even minor stage 1 endometriosis, the chance of having a baby is 5 to 6 times lower. So the chance of a pregnancy drops to about 4%, and the chance of a baby drops to about 1 or 2%. And the chance of having a baby is not 80% per year, but 40% within 4 years. This just explains why this condition is often overlooked and what makes often underrated. Oftentimes a doctor will say to you, you know what, we went in and did a laparoscopy and we burnt away or lasered away all the endometriotic deposits. You're fine now and you should be able to have a baby because your tubes are open. And by the way, you should know, folks, endometriosis rarely damages the tubes until it's much more advanced, rarely blocks them. So that the doctor goes in, does the surgery, and says, you've got a better chance. And he's dead wrong. Because for every little spot of endometriosis that he's lasered, there are probably another 20 or so coming up. And it's a work in progress, and it's there until you go through menopause. So doing surgery is not going to get rid of the toxic effect of endometriosis. It has no ability to do so. And that is why a woman who gets pregnant, because let's bear in mind again, let's picture this now. Endometriosis does not make a woman sterile if it's early endometriosis. It simply reduces her chance of getting pregnant. Let's say she gets pregnant on her own, or worse still, she goes to a doctor, he puts her on Clomid or even injectable fertility drugs and does intrauterine inseminations. And she happens to get pregnant. So she gets pregnant, but now she tries to have a baby again. And she can't get pregnant the second time. Why? Because the toxic factors are still present in the pelvis. She was lucky. It was a fluke that she got pregnant with the fertility drugs or with the surgery or the intrauterine insemination. Because they can't assure you that the other lesions that are there coming up will not produce toxins as well and prevent pregnancy. So whether or not you do intrauterine insemination, whether or not you give fertility drugs, whether or not you do surgery to get rid of endometriosis, you do not improve the chance of a baby per month of trying in a woman who ovulates normally on her own than would occur if you did no treatment. So what is the treatment of this condition then? The treatment of endometriosis is to make sure that you treat the woman, that you either take a wait-and-see approach, or you do IVF to bypass the pelvic environment that's hostile and toxic. Please bear in mind, it's essential that you don't think that the surgery or the IUI or fertility drugs is going to solve your problem. Surgery doesn't get rid of the lesions you don't see. It only gets rid of those that you can see. And IUI just injects sperm higher up. It does nothing to alter the environment through which the egg must pass to get to the sperm. IVF is the only way to improve the chance of pregnancy. But I'm not suggesting for 1 minute that IVF is meant for everybody. In a young woman in her early 30s or late 20s, why would you do IVF if she's willing to wait it out? She may still get pregnant. It's a less of a chance, but she still has got that 3 or 4% per month and that 40% within 4 years of getting pregnant. If she's willing to wait it out, she can try. But women who have diminishing ovarian reserve and are running out of eggs with a raised FSH or falling AMH level, and women that are over 35 where their eggs are declining in quality, simply don't have that kind of time to waste. So these women should go directly to IVF. It is a work in progress, remember that. In some cases, you get pelvic adhesions, but tubal obstruction, as stated here, is a rarity. It only occurs in the much later stage of the disease. Pelvic adhesions can form in the pelvis because of these adhesions, and this can prevent the tube from moving around to pick up the egg the way it should, so that can also be a factor. As the scarring from endometriosis progresses in the pelvis, it cuts off blood supply to the ovary. And as it does this, the ovaries become unable to produce as many eggs, and the woman can go into an earlier diminishing ovarian reserve, which creates problems in and of itself, and this is more common in the advanced variety of endometriosis. Then there's a condition called endometriomas, and that's where the little deposit in the ovary bleeds, the blood collects and undergoes decomposition, and when it decomposes it looks like melted chocolate, so we call them chocolate cysts or endometriomas. These will then, through osmotic suction, pull fluid into the cysts. They can grow and grow, and I've seen it as large as a football, but usually they're small. They're about 1 to 2 to 3 centimeters. Here's the problem with endometriomas in the ovary. If there's an endometrioma in your ovary and it's more than 1 centimeter in size, it will activate the surrounding connective tissue in the ovary, causing an increased production of male hormones in that ovary called testosterone and androstenedione. These male hormones interfere with egg development, so that ovary that has the endometrioma is more likely to produce poor quality eggs. The treatment is to remove the endometrioma before you do IVF, in my opinion, in the hope of trying to improve egg quality. You can remove it laparoscopically, but then you've got to remove the entire endometrioma. You can't just drain it, it'll come back always. You can't just burn it here and there. You've got to completely ablate it with diathermy, or you've got to use a laser to kill the entire capsule that lines the inside of the endometrioma, or it'll just come back again. So surgery can be used as one option. A new method that we introduced some 10 years ago is known as sclerotherapy. It's highly effective. I'm not going to go into it now. I urge those of you who are interested to go elsewhere on my blog, ivfauthority.com, and look for the article I wrote on sclerotherapy, or find it in my book, In Vitro Fertilization, The Art of Making Babies. There is an article on this. It can be done as an outpatient. It's much less traumatic, and it is highly effective. But it should only be used in people for whom IVF is indicated, because sometimes the tetracycline we inject into the endometrioma leaks out and can cause irritation and scarring in the pelvis. That's not a problem unless you're trying to get pregnant on your own. So treating endometriomas by sclerotherapy should be reserved for women that need or demand, or for whom IVF is the only alternative. And then there is the last one, and that is one we're going to talk about in greater detail, and that is in a few moments, and that is autoimmune immunologic implantation dysfunction. Now, here you need to know that 60% of women who've got endometriosis, regardless of the severity, will have antibodies to phospholipids. We call them antiphospholipid antibodies. They can be problematic in the embryo's attachment in the uterus. And a third of women with endometriosis will have activation of cells in the uterine lining known as natural killer cells. All women have got natural killer cells. Their role is to regulate the implantation of the roots into the wall of the uterus and triage the formation of the placenta, which is the lifeline for the baby. If these natural killer cells, which comprise 75% of all the immune cells in the uterine lining, and they're vital for normal conception and nidation. If they are toxic, if they've become activated in cases of endometriosis, and that happens in a third of cases, they start to release toxins known as Th1 cytokines that attack the roots of the embryo and can often destroy it before the woman even knows she's pregnant. She thinks she's not getting pregnant, but she's having many miscarriages over and over again so early she never knew she was pregnant. Or it damages the roots of the embryo, and the embryo limps along till it runs out of steam and miscarries. So when a woman has endometriosis and you're considering conservative treatment, not only should you consider the fact that you're not helping much by doing surgery to try to ablate the lesions or doing intrauterine insemination, but you should also test the woman for activated uterine natural killer cells, because if they're activated, she needs IVF with immunotherapy using intralipid and steroid, and we can talk about that at a later stage. As I mentioned earlier on when we started, I'm going to be doing another important webinar by popular demand at the end of January, 29th of January next year, on the role of immunotherapy and the role played by the immune system in the infertility and IVF arena. Those of you that have an interest or know people that would be interested should contact Tom, as I indicated and will show again at the end of this presentation, to register for that webinar. So let's go on to the last one. First I want to show you a couple of pictures. These are endometriotic deposits. Notice it's on the bowel here. Notice that it can be on the uterus. It can be on the ovaries. And notice that here we see these deposits at closer range. Here are a few adhesions between the uterus and the tube. There's the fallopian tube. There are adhesions. There's endometriotic deposits. Here you can see some of them that have just occurred because bleeding has occurred into these lesions with menstruation. By the way, folks, endometriotic deposits can be invisible. They can be completely translucent, so you won't even see them. You've got to be aware that when there are symptoms of endometriosis, you've got to suspect it. You can't diagnose the condition without seeing the lesions through laparoscopy, unfortunately. But you should suspect it in any woman who has very heavy periods for no explained reason, who has a lot of pain with her periods and experiences pain with intercourse and pain with ovulation. These are typical symptoms of women who've got endometriosis, even mild endometriosis. These are ultrasound pictures of endometriomas. It looks like the snowstorm appearance. It's unmistakable. When you do an ultrasound, you can see them, and these lesions can be accessed through sclerotherapy or can be removed surgically, as I described earlier. Here is a large endometrioma on the ovary. You'll notice it here, seen at the time of laparoscopy. So now let's get to the last point before we open up for questions, and that is immunologic implantation dysfunction. I've just mentioned to you that you get a situation where you produce natural killer cell activation in response to what we call an autoimmune condition. That's the body reacting to its own tissues. One example is endometriosis. Another example is hypothyroidism or Hashimoto's disease, where the woman has antibodies to her thyroid. You don't have to have the condition. If you've got these antibodies, you have a 50-50 chance of having activated natural killer cells. And another one occurs in women who've got autoimmune diseases such as lupus erythematosus, rheumatoid arthritis, scleroderma, dermatomyositis, and we could go on and on. But the important thing to know here is that this condition, which is autoimmune activation of natural killer cells, is easily reversed with treatment with intralipid and steroids. And it's not dangerous. It causes very few side effects, and if given properly, is without real risk. It's given always in combination with steroids to be effective. You can't treat with intralipid alone. You've got to use dexamethasone, prednisolone, or prednisone along with it. That's autoimmune, And you don't have to have the condition. You can only have a family history of any of the conditions I mentioned as a possible cause of autoimmune implantation dysfunction. It comprises almost 80% or 75% of all immunologic implantation dysfunction associated with natural killer cell activation. And the treatment is steroids and the use of intralipid. It's important that you understand that this is the one that's the most common, easy to treat. More usually than not, this type of immunologic implantation dysfunction causes just failure to conceive. The woman doesn't even know she is pregnant. She lost it so soon. She lost it early. It's not usually the type of condition that is associated with recurrent pregnancy loss. And that's not the one I want to focus on, because very often with this autoimmune variety, the history or the family history or the personal history of endometriosis, lupus, hypothyroidism, rheumatoid arthritis will alert you to the possibility, and then you test for the antibodies, anti-thyroid antibodies, anti-ovarian antibodies, anti-phospholipid antibodies, and natural killer cell activation using the K562 target cell test. And you'll pick the diagnosis up. If there's no activation of uterine natural killer cells, it's usually pretty innocuous. It's not usually that bad, that dangerous. But if there is activation and you don't treat it, the chance of a successful pregnancy is very small. What I want to talk about here is really another variety of activation of natural killer cells, one that is so commonly missed. I had a patient today that fitted into that category exactly. This is a woman that went ahead and had a baby with her husband. In fact, she had 2 babies in this case. And then after that was unable to conceive again. And she had no underlying pathology. Laparoscopy was normal. Husband was fertile. Tubes were open. She was young, in her mid-30s. Still, she couldn't get pregnant. When that happens, this type of secondary infertility, and especially if the woman miscarried several times before she became infertile, is very often due to a rarer form of immunologic implantation dysfunction known as alloimmune implantation dysfunction. Alloimmune is distinct from autoimmune, which I've already discussed. With alloimmune implantation dysfunction, your body isn't reacting to its own tissues. It's reacting to the tissues of another individual. And here it is the male sperm, as it fertilizes the egg, that transmits a genetic signal or the paternal antigen from the man to the egg, and that embryo is now imprinted with the paternal antigen. The genes that we're specifically interested in here are known as DQ alpha and HLA. DQ alpha and HLA, mostly the former, DQ alpha. If the man's DQ alpha in in the sperm that fertilizes the egg matches the DQ alpha of the woman's body, this is not about the egg and the sperm, it's about the sperm and it's the man matching the woman as evidenced by his sperm's genetic makeup. If the embryo is imprinted with a DQ alpha that matches that of the woman's body, then that embryo reaches the uterus, even if it's normal in every respect and would otherwise have made a baby, it will almost certainly not propagate a viable pregnancy if and only if, in addition to the matching, there's natural killer cell activation. Now I want to make this point. Natural killer cells don't get activated very often in the very first exposure to an embryo where the husband's sperm DQ alpha matches the woman's uterus. It usually takes repeated activation, so that if that happened in the first pregnancy that she got pregnant, even if there was a match, but there hadn't been time for the natural killer cells in the uterine lining to become activated because of that similarity between the man and the woman, then that pregnancy will go on and usually proceed to have a baby. But when the woman comes along wanting to have a second child, then she very often will be unable to or will miscarry because of the similarity. This is how alloimmune implantation dysfunction can cause secondary infertility with nothing else wrong. And I see it more and more. Couples come to me where they've had a baby, they've been tested every which way, and there's no explanation for why they're not getting pregnant again, and it's not autoimmune. We then test the husband and the wife's DQ alpha and HLA to see if they match, and test the woman for natural killer cell activation. If you have activated natural killer cells, uterine natural killer cells, plus you have a match, then you have a problem. And when the embryo gets into the uterus, if it matches, giving intralipid and steroids, or anything else for that matter, usually is ineffectual. I repeat, it's usually ineffectual. You can't solve the problem through treating with immunotherapy when there is a match. What you've got to do is wait till there's no match and then treat. And if that embryo gets the uterus, then the use of the intralipid and steroid will downregulate the natural killer cells and T cells, and then the embryo, if it doesn't match, will take. But what's this I'm telling you? I just told you a few moments ago that they match. If the husband is carrying the gene, he'll imprint it into the egg. But what you need to bear in mind is that in most cases, when there is a match, it is not a total match. There are 2 DQ alpha genes in each person. One came from your mother and one came from your father. So the man has a DQ alpha from his mother and his father. When the sperm matures, the sperm divides in 2, and one sperm will have the DQ alpha from the mother and the other sperm will have the DQ alpha from the father. It therefore depends upon which sperm fertilizes the egg. If the egg is fertilized by a sperm that came from the DQ alpha of the mother or father, and that DQ alpha didn't match, then that embryo will be perfectly fine, except for the fact that if the natural killer cells are activated, you've got to downregulate them first. So you treat the woman with intralipid and steroids, and you then put back one embryo at a time. That's my opinion. One embryo at a time. Because if you put back 2, it's just possible that you will have the other embryo resulting from the fertilization with a sperm that carried the DQ alpha similarity, and now it'll muddy the water for the good ones and neither will take. So for that reason, single embryo transfers, when there is a partial DQ alpha match, is what is indicated, with a woman having been treated appropriately with intralipid and steroids up front. If you do that, and you put back one embryo at a time, granted, the chance of pregnancy per embryo being transferred will be half that of what it would be in the absence of a match, because 1 in 2 is going to carry the match. So you've got to warn the patients that it will take time. You just keep putting back one embryo at a time, and to improve the chances, all you do is you then test the embryo to make sure that the one you're putting back not only you're putting back one in the hope that it has a 1 in 2 chance, but 1 in 2 chance if the embryo is chromosomally normal, having done CGH analysis on the embryo to make sure it's normal, will double the chances of success. Let me give you an example. If the normal chance of an embryo making a baby, in the absence of knowing whether it's chromosomally normal or not, is 30%, and you put one of those embryos into a woman with DQ alpha match and natural killer cell activation, the chance will be 15%. But if that embryo is CGH normal, it now has a 60% chance or more of making a baby in the absence of a DQ alpha match. You put back one embryo like that, that is normal, it's now half of 60%, not half of 30%, and you've just doubled the efficiency of the process. And so that is why when I do IVF on patients who have a partial DQ alpha match with natural killer cell activation, I put back one embryo at a time, and I try to convince the patient that it's in their interest for us to test the embryos to see which ones are normal, to double their chances of having a baby with one embryo. Now here's a big problem. You might ask, why don't we just test the embryo to see what the DQ alpha is of the embryo? Well, as yet there's no way of doing that. We don't know how to do that. And that's why we keep putting back one embryo at a time, hoping that the number will come up when the right embryo that gets the uterus will not match and will be chromosomally normal, and that embryo will make a baby only if you treat the natural killer cell activation with intralipid and steroid. Now, some people are still using IVIG. I used to use IVIG. We were amongst the first people in the world to use IVIG and IVF. But it is no longer necessary because intralipid will do the trick of lowering the activated natural killer cells, down-regulating them. Now, why the steroid? Why not just the natural killer cells be treated with intralipid? Because of this guy. The T cells, the cytotoxic lymphocytes, they are not down-regulated by intralipid. They need steroids to down-regulate them, and they work hand-in-hand with natural killer cells to cause the problem. If you don't suppress them as well, you don't get a maximal therapeutic effect. So, who is then at risk? As I told you, who is at risk of having activated natural killer cells? Women with secondary infertility where there's no other explanation as to why they can't get pregnant. Cases where there's secondary infertility after recurrent pregnancy loss. Women with endometriosis. Women with unexplained infertility. And women with repeated IVF failures where there's no explanation for it. And anybody with a personal family history of autoimmune disease. I'm not going into the treatment again. I just want to close and open for questions with one final point. Please, folks, those of you who want to have a consultation to discuss your problem with me, call 800-780-7437, 1-800-780-7437, and ask Tina to book you for a Skype consultation, and we'll discuss your case in detail. If you live outside the United States, call 702-699-7437. 702-699-7437, and Tina will set up that Skype consultation. I want to alert all of you that have a special interest in the immune issues of infertility and recurrent pregnancy loss that I'll be doing an entire webinar on this by popular demand on January the 29th, 2015. I urge you to contact Tom Anderson at tomanderson@integramed.com, tomanderson@integramed.com, to register up front for that webinar, because we can only have so many people attend, and after we get to the limit we have to shut it off. So please call Tom. First come will be first served. Thank you very much for your interest, and I certainly hope you found this stimulating and have questions you'd like to ask. So now we'll go to the questions, and here's the first one. Darlene writes, would Raynaud's phenomenon pose an autoimmune risk despite negative ANA-APA panel? Yes, Darlene, it could. You should have a natural killer cell activity test done, and that test is called the K562 target cell test. The two best laboratories in America, in my opinion, that do this test with the optimal sensitivity and specificity are, number one, ReproSource in Boston, Massachusetts, and the other one is Reproductive Immunology Associates in Van Nuys, Southern California. RIA, Reproductive Immunology Associates, and ReproSource in Boston. The next question says, Carolina Zambrano writes, I've had 5 pregnancies total. All tests come back normal in both me and my husband. I don't understand. And then you write again, I've had 2 miscarriages before my 3rd pregnancy, which was a healthy child. Then I've had 2 miscarriages after that as well. My daughter's 2.5 and I want another baby. Again, I mentioned to you, Carolina, you need to be tested for the immune issues, because you also, as you state here, have endometriosis, and you need to be checked. So you need a natural killer cell activity test, the K562 test, tests for antiphospholipid antibodies or APA, and I told you how to get access to them. Do you recommend any homeopathic treatments? You know, more and more we're beginning to look at these, but the truth is there's no proven benefit from homeopathic approaches. I have a feeling that the use of antioxidants and possibly omega-3s such as fish oil at a dosage of 2,000 milligrams a day might have a benefit, and it's worth a try. There is another question from Jen W. I had a DNC for retained placenta after my first birth. There's significant scarring, Asherman's. If the scarring can be cut away, what are the chances of successful pregnancy? Jen, that depends upon whether or not the endometrium can measure at least 8 millimeters on the day of ovulation or HCG. If it can't, then you can try Viagra therapy, vaginal Viagra with estrogen, and if that doesn't work, you can try it along with antiprostaglandins like aspirin or indomethacin, and if none of those work, nothing's going to work, I'm afraid, my dear. You'll have to be looking at a gestational surrogate. Or gestational surrogate. Carolina Zambrano writes again, what specific test should I be asking for? I think I told you that already. A full APA panel, natural killer cell activity by the K562 target cell test. I know there are those programs that are doing cytokine testing on the blood. I'm not convinced it has any benefit. I may be proven to be wrong, but as yet I don't believe that this is a proven entity, although some people are recommending it very strongly. I'm about to embark on a study in the next few months to see whether there is any merit in it, but right now I believe that the gold standard remains the blood test done on the woman known as the K562 target cell test. And remember, it is not the concentration of natural killer cells that matters. It is their toxicity, their activity that you're measuring. Darlene writes, you've asked me that already, I said that. No more questions. That's all. We're getting off lightly today. No more questions. Wow. If there's anybody that has any additional questions, now's the time to pose them. Or otherwise, I'm going to call it quits and wish you all a wonderful evening. And I thank you all so much for attending this webinar and look forward to hearing from you. Here's another question. Why would every RE tell me that I should absolutely do Lovenox upon positive test? Lovenox treatment is for women that have antiphospholipid antibodies. But alone it is not good enough if there are also natural killer cell activated, if there are also natural killer cells that are activated. So Lovenox is fine if you have phospholipid antibodies, but not if there's natural killer cell activation present. Okay. Melissa writes, I was just diagnosed with Sjogren's syndrome, about to do my first IVF. I have borderline ANA and SSA is positive. Should I be concerned? Absolutely, Melissa, I would be concerned. And I would personally, if I were you, strongly recommend that you don't proceed until you've done the K562 test in your blood. And if your doctor says he doesn't believe it, then ask him why he doesn't believe it. Ask him to explain to you what it is that he doesn't believe. I strongly recommend that you get this tested, yes. Do you know of any clinics in Canada that can do NK cell testing? No, I suggest you use the two labs I recommend. Your blood can be sent Federal Express overnight to Reprosource or RIA for the testing. It takes 10 days to get the results. Are we done? Thank you all very, very much indeed. I appreciate your attendance and look forward to seeing you again at the end of January. Have a wonderful evening.